Hi, everyone. My name is Siqi, and I'm a combined fourth year MD/MS student applying into general surgery this coming cycle. Thank you for joining me as I talk about my research with Dr. Forrester about how infection with two or more multi-drug resistant organisms after solid organ transplantation is associated with increased mortality. So, in the last half decade, more than 35,000 patients per year received solid organ transplants to treat end stage organ disease in the US, and that number is still increasing. Patients receiving solid organ transplants have many risk factors for infection with multi drug resistant bacteria. Their immune systems are dampened owing to varying degrees of critical illness and surgical stress. Induction of immunosuppression further impairs their immune response to acute infection. Perioperative broad spectrum antibiotic therapy promotes selection for multi drug resistant pathogens, and increased length of stay following transplantation increases exposure to pathogens. Infection with multi drug resistant organisms after solid organ transplantation has been associated with increased mortality, transplant organ complications, and prolonged hospitalizations. Because of their high susceptibility to multi drug resistant infections, transplant patients frequently experience multiple multi drug resistant infections during hospitalization. Unfortunately, previous studies of solid organ transplant recipients, including liver, heart, lung, and kidney, fail to differentiate patients with a single multi-drug infection from patients with multiple multi-drug resistant infections. So in this study, we sought to clarify the effects of multiple multi-drug resistant infections on solid organ recipients. And we hypothesized that increasing numbers of multi-drug resistant infections would be associated with prolonged hospitalization and worse in-hospital mortality. So this is a cross-sectional retrospective study using data from 2016 HCUP NIS. It's built from discharges from more than 4,000 US community hospitals. We used ICD-10 codes to identify admissions with transplantation of liver, kidney, heart, lung, and pancreas. Our outcomes were death during hospitalization and duration of hospitalization. We also looked at potential confounders such as age, sex, race, ethnicity, income, and primary payer, and number of comorbidities. So in our study, multi-drug resistant diagnoses were modeled as either a binary variable, so no infections versus diagnosis of any number of infections, or as a model with independent subgroups. So zero infections, one infection, or two infections. And all effects were adjusted for confounders. So the big takeaway from our study is that in the transplant population, when we evaluate infection with multi-drug resistant organisms as a binary variable, the odds of death is not significant and modest. So odds ratio of 1.8, as you can see here. However, when we break that down into one versus two multi-drug resistant infections, we see that patients with two diagnoses have much worse outcomes compared to patients with zero diagnoses or one diagnosis. So it seems like it's really the group with two multi-drug resistant infection diagnoses that's driving this decrease in a worsening of outcomes. And there's a similar trend in hospitalization, but the effect appears to be more linear. Diagnosis of one infection is associated with a 20-day increase in hospitalization, and diagnosis of two infections is associated with a 41-day increase in hospitalization compared with those with zero diagnoses. And overall, in this study, there were zero patients with three or more multi-drug resistant infection diagnoses. Overall, our results are more modest than those reported in previous studies. So in 2018, there was a study showing infection after liver transplantation led to a 13.3 increased odds of death. There's another study showing that vancomycin-resistant enterococcus infection was associated with a 2.65 increased odds of death. There's several reasons why our results may be more modest. So first, this study is cross-sectional, retrospective, and is less likely to capture multi-drug resistant diagnoses. As a result, that misclassification bias in our analysis may have led to an underestimation of the true effects of multi-drug resistant infections in our patients. Another possibility, and what I hope to be true is that detection and treatment of multi-drug resistant infections has improved, and outcomes in transplant patients have improved in parallel. And perhaps improvements in management of a single type of multi-drug resistant infection is contributing to diverging trends in mortality for patients with one versus two infections. So for future directions, based on our data, it seems like the outcomes for patients diagnosed with one multi-drug resistant infection versus two are very different. So future studies investigating outcomes from multi-drug resistant infections should evaluate one versus two infections independently. Another is that um, our cross-sectional study lacked data about the temporal nature in some of these exposures versus outcomes. So we aren't able to show that it wasn't length of prolonged length of hospitalization for more ill people that led to perhaps increased number of diagnoses that then led to worse outcomes. So, future studies to try to establish a true causal relationship between um, exposure to or diagnoses of one or two multi-drug resistant infections and mortality need to establish that temporal connection. A huge thank you to Dr. Forrester for his mentorship in this project. I've learned so much and I really appreciate your incredible support. Also, thank you to Lakshika for helping with data and for feedback on statistical analysis. And lastly, but not least, thank you to Dr. Brubaker for providing incredible expertise in solid organ transplantation. And thank you to all of you who listened to this talk. I hope you learned something. Thank you very much.